let's get started. So our journey begins. So we've got 3 separate routes we can take today in the conference based on these 3 images, which we will describe what all these images are by the end of it. So for people in the conference or people watching, which one of these images do you guys want to start with?
The Mist. Definitely The Mist.
The Mist, perfect. So Dante, do you know what movie this is from?
The Mist.
The Mist.
By Stephen King.
Yeah, so Dante is correct. That's Thomas Jane, famous actor in The Mist, based on the book The Mist by Stephen King. It is
The Mist just one more time.
Yeah, The Mist. It's an absolutely terrible movie, but we're going to start there. Okay, so our chief complaint for the first case is rib pain. So HPI, we've got a 32-year-old man with obesity presenting with a 2-week history of progressive right-sided rib pain. Symptoms started on the right side and wrapped around to his back. It's exacerbated by deep breaths and movement of the right shoulder. No improvement with ibuprofen or Tylenol. And 1 week prior to presentation, he developed fever, chills, and productive cough with green-yellow sputum. He's got obesity, but no other known medical problems. He has no relevant surgical history. Family history of coronary artery disease and multiple MIs from numerous people. Social history. Used to previously drink heavy alcohol, but quit about 5 years ago and has been abstinent since. He's a never tobacco smoker, and he's never used drugs. So for one of our medical students or interns in the room, what illness script is this HPI, chief complaint, et cetera, kind of triggering for you guys?
I think it's pneumonia.
Perfect.
Lung pathology.
Perfect. So pneumonia, lung pathology, I completely agree. So exacerbated by deep breaths, movement of the shoulder. So something is irritating this man's pleura and causing him pain. Okay. So let's get a workup then. So his initial vitals in the ER, he's afebrile at 36.4. He's initially a little hypotensive and gets more hypotensive while he sits there. Heart rate is 112. Respiratory rate is 27. He's setting 90% on 2 liters. You do your physical exam, he's acutely ill appearing. He's got dry mucous membrane. His right, mid, and lower lung have crackles and bronchial breath sounds. He has cacophony as well. He's tachycardic but has no murmurs. So I'm going to give you the basic labs that the ER calls you about. Notably, his white count 14.3. His EMT is notable for a low bicarb, an elevated creatinine, and a glucose of 626. And he's got an elevated beta-hydroxybutyrate, an elevated lactate, an elevated procal, and a low BBG. So for our residents in the room, based on the HPI, vitals, exam, and lab, give me a quick differential for what's going on with this guy.
Well, it's not very high on my list, but given his elevated beta-hydroxy, his low bicarb, you could say DKA, elevated glucose.
Perfect. So that's great. He's definitely in DKA. And what did we talk about? A little bit of space learning. So last week we talked about kind of Dr. Kearns' 5 I's of DKA. So right, DKA is always due to something, whether it's a lack of insulin or something triggering the DKA. And so what do you guys think, just based on this history in the exam and the labs, what might be triggering this gentleman's DKA? Cool. So of our eyes, we're thinking possibly infection. And if you guys had one diagnostic test to order next, what would it be? Perfect, a chest x-ray. So we've got a chest x-ray. I need to erase some stuff here. The chest x-ray is in order. All right, so I'm going to ask one of our upper-level residents in the room, who's not Adam, to read this chest x-ray. So, Paul, why don't you go ahead and give us a shot at this chest x-ray?
What do you want? Oh, here. Yeah, sure. So, without going into all the ABCDs, it seems like the most obvious thing is the right lower lobe or middle lobe opacity, kind of the white out consolidation. That's all mostly what I see. I don't see anything on the left side, no pleural effusion or anything like that with the costophrenic angle blunting. So I'd be concerned about an infectious process. But there's alcohol use, maybe aspiration in the right middle or lobe.
Perfect. Yeah, that's a great read. So Paul gave a very focused, upper level resident read, which is great. So what Paul talked about was he's concerned for a right middle and right lower lobe infiltrate. And the reason he's saying that is because of something called the silhouette sign. So, right, typically we should see the diaphragm right there. We should see the heart border right there. And if we lose those two structures, then we assume that there's pathology in the lung surface that's touching that structure. And so the thing that touches the right hemidiaphragm is the right lower lobe. And the thing that touches the right heart border is your right middle lobe. And so we can assume from those two things being gone that something's affecting that. Paul, what do you make of this area up here?
I see, I mean, it's not as, I mean, it looks more like a alveolar filling process there. It's not like a consolidation. And I see some fissures there. So I'm not sure if it's like a fluid collection there or something like that.
Perfect. So Paul brings up a good point. So he sees an alveolar filling process, but he also sees kind of the median fissure right there. And so whatever this is extending above the median fissure. And so the next thing then would be, right, look at a lateral. And so on the lateral here, I'm going to ask a different resident now. So we'll go to Dante to give us a read of the lateral. And Jacob, you can just pull the chat down over there on the side.
I need to get in a position where it's not like reflecting. A little bit.
Yeah, I mean, you can see the continued consolidation, but there's also like a weird, like delineation kind of in the middle there. There's like that airspace opacity that I'm not really sure what to make of that, but it looks very like almost straight. And apparently there are no good straight lines in the body. But yeah, that's kind of what I'm seeing there. And then diaphragm still looks good. There's some substanding angle, no effusion that I can see, at least on the lateral side. I don't know if there's anything that I'm missing in particular. I probably am, but kind of what I'm seeing.
No, that's great. I'm going to ask Adam, do you see anything else on here that Dante or Paul hasn't pointed out yet on the lateral?
Well, just, you expect that the spine is more loose, and then you go down and you see that it's, there's opacity there. So think about that spine sign. I think that line that you're seeing, like kind of in the mid lung, is the arm.
Oh, gotcha.
Awesome. So for those of you who don't know, that Adam is a former radiology resident who saw the light and joined internal medicine. But he's correct. So on the lateral, we've got something called the spine sign. And so what the spine sign is, which Dante was also describing, is as you go down the spine, it should get darker because there's more area between the vertebrae and there should be more aerated lung. And here you see the opposite. You see an opacity as you're moving down the spine. And so the thing that we were actually looking at on the frontal on that side, extending above the median fissure, was actually a posterior consolidation. So there's actually two separate consolidations in this man's chest. So what are you guys going to do next? You get this x-ray, this man is in septic shock now in the MICU, and you're standing in his room. What diagnostic test do you want to perform next?
Maybe like a pneumonia workout, like a urine strep and Legionella.
Okay.
All those tests.
Cool, so we'll send up a urine strep and Legionella, that's great. Still standing in the room, and you've still got another diagnostic test to do.
Blood culture.
Blood cultures. He's now heading towards intubation, so he's now setting 90% on heated high flow. Okay, we got an ABG, cooking. Anything else you guys would like to do?
Diagnostically.
Throw an ultrasound on?
Yeah, we'll throw an ultrasound on him. So you throw an ultrasound on, and he's got a huge effusion on that right side, which Meryl said as well. So you are standing in the room with Dr. Kearns. This is a real-life situation. Dr. Kearns says, I'm going to do a thoracentesis on this man. And jumping ahead, these are the pleural fluid studies that you get from that thoracentesis, diagnostic. So it's purulent. He's got a ton of white blood cells. His LDH is off the charts. His protein's high, and his pH is less than 6.8. So Meryl says, yikes, which is the appropriate response to this. But for one of our interns in the room, what do you guys make of these pleural fluid studies?
Like grossly extubated.
Perfect. So Julie says grossly exudated, which is absolutely correct. And then if you were going to even put a more specific name on it, what would you call this? Cool. Paul correctly says this man has an empyema. We correctly diagnosed this man with strep pneumonia, and just to keep things moving, he has septic shock from strep pneumonia. So he's got an empyema. You guys have elected to put in a chest tube. So to tie it back to Thomas Jane and the myth, how do we decide what to do after we put in a chest tube? What medicines do we have to also give this person?
Antibiotics.
Antibiotics, perfect. And then do we do anything in the chest tube? Awesome. So Merrill says alteplase, great. So to tie back to Thomas Jane, this is a study from 2011, and this study is the MIST-2 trial. Came after MIST-1, and essentially what this trial looked at was a number of things, but it looked at TPA and DNA versus TPA versus DNA versus placebo. And does anyone want to take a guess in the room what this study found?
Person study. For TPA, DNA. Am I feeling better? Use that all the time.
Yeah. So Paul correctly points out that if we do something all the time here, there's probably some evidence behind it. And so TPA DNA was the best choice. And so what it did was it reduced the radiographic opacity. So it reduced the opacity. And then it also decreased surgery. And so essentially by giving people TPA and DNase, you can break up loculated empyemas and effusions, and you can help it drain through the chest tube, which theoretically should have some benefit. Interestingly, in the study, TPA and DNase did not show any benefit by themselves, and placebo still gave a 17% recovery rate. And so the recovery rate was 29% with TPA, DNase, and 17% versus placebo.
So the role is really just to break things up. It's not to cause any pleurodesis or anything like that. It's just to like get that effusion room.
Yeah, great question. So Dante asked if it's just to break things up, and that's correct. So it's just to break it up, and it's just to facilitate drainage. And so when we do TPA and DNase, we do it for 3 days, and we do it twice a day. So it's a BID thing. So you take it, you instill it, you let it sit for an hour, and then you let it drain back out through the chest tube. So for the interns in the room, if you guys have not done this yet, during the year you will be called to instill TPA and DNase into someone's chest tube at 1 in the morning, because that's when the 12-hour limit hits. You'll have to instill it, you'll have to drain it, and you'll have to tell the team in the morning that you did it. And we do that because of the MIST-2 trial. Okay, so this man gets 3 days of TPA DNase, and then he gets a repeat CT. And then here's what his repeat CT shows. All right, so the chest tube popped up there in the middle, right about there. But what do you guys make of those CT findings? Not great, yeah. So this man still has infection in his chest. So because he still has infection in his chest, you have to call CT surgery for him to get a VATS. So hospital course for this gentleman. So his final diagnosis, he had septic shock due to strep pneumo community-acquired pneumonia, complicated by a multiloculated empyema and DKA. Notable events, he was enrolled in the fever trial at Denver Health, which is looking at whether early VATS versus TPA and DNase changes outcomes. So if you have a patient with an empyema at Denver Health, call surgery. He got a right pigtail catheter, and he got 3 days of TPA. He had 3 liters of purulent output, but that CT still got worse. So he got a VATS decortication, 3 chest tubes, but thankfully, after the VATS, he had source control, he got better, and he was discharged home a few weeks later. And so this man was actually a good outcome, but was in the hospital for quite a while dealing with a pretty serious pneumonia. All right, so let's move on to the next case.
Is there any difference between the little IR chest tubes versus the big surgical ones and outcomes?
Yeah, good question. So Adam asked whether there's a difference between small chest tubes and large chest tubes. In the MIST-2 trial, the majority of people had 15 French or smaller. So they have smaller chest tubes, and there was comparable outcomes across all groups. I think when they've looked at large versus small, there is not a significant difference. There's just more patient discomfort the larger the chest tube is. Okay, so you guys have, we've X'd out Thomas Jane here. You've got 2 more things to go. Which one do you want to do next?
I already said my piece.
Let's do mountains.
Mountains, perfect. So we're going to do the mountains. Does anyone know what mountain range this is?
Himalayas, I don't know.
The Alps.
We will find out soon enough. Okay, so this gentleman's chief complaint is chest pain. So he's a 37-year-old man with arthritis, alcohol use disorder, brought in by ambulance from outside a liquor store with chest pain and shortness of breath for 1 day. He can't give you any further history because of how sick he is. Past medical history, he has arthritis of an unknown duration and time. He has alcohol use disorder, drinking quite a bit per day. He has an unknown surgical history, unknown family history. His social history, like I said, he's a heavy alcohol user. He's a never smoker, never used any other drugs, and he's currently homeless. So we'll do the same workup we did last time. We get some vitals in the ER. He's febrile. He's hypotensive to the 80s over 60s. Heart rate's 150. He's breathing 35 times per minute. He's satting 88% on room air. He's intubated in the ED because he's progressively more hypoxic on heated high flow and non-invasive. And that's the point that you're called as the MICU intern or resident. So in his exam, he's acutely ill. He's diaphoretic. He's using every muscle in his body to breathe. He has right chest wall tenderness when you're pressing on him. He also has agopony. He's also tachycardic, and he has very numerous joint deformities and contractures from long-standing arthritis. His labs got a white count of 2, a hemoglobin of 11.4. His entire BMT is red. His LFTs are mostly red. And then I'm going to ask Jacob to pull the chat sideways there. But his other labs, he has a lactate of 13, a beta-hydroxybutyrate of 5.6, a procal that's incredibly high, positive alcohol level, and an ABG that can best be described as garbage. Okay. Anything else you guys would like to add on to this man's labs right now? Okay, blood cultures.
I'd probably get an HIV screen.
HIV screen, perfect. And why do you say get an HIV screen?
I mean, he's orthopedic, and he's homeless, and he's some higher risk factors. I mean, I'd probably do like HCV and all that stuff too, but just thinking about his social status.
Perfect.
Yeah.
Perfect. So Dante and Anita both said they want to add on some stuff. And so you add on a diff, and you find out that he is indeed lymphopenic. You confirmed it. He has 300 absolute neutrophils, which is certainly below the limit. And HIV cultures and additional testing are all added, and we'll talk about those in a second. All right. Next test you want to order. Chest X-ray. Perfect. So we've got another chest X-ray. This time we'll have one of our interns read it. So, Evan, take it away.
Very similar to the last one. You got right lower and middle lobe infiltrates. Nothing fits the upper lobe, and we also have some left pericardial hilar fullness of the heart. And then another pleural effusion on the left side, potentially on the right. Looking at breast bones. Looks like this is before he was intubated, when it comes to the endotracheus.
That's a great read. That's excellent. So you astutely pointed out this is fairly similar to the last chest X-ray. And correct. So once again, right, we don't really see that right heart border. We don't see the right hemidiaphragm. This is his median fissure, and it's sort of bulging upwards. And then Evan pointed out on the left side, there's some perihilar stuff here. And then if you kind of follow your eye down there, there's also some stuff down here. And so the official read was that this man has a multifocal infection with significant consolidation in his right middle and right lower lobe. So before he comes up to the MICU, you ask that they get a CT of him. And here's his CT. So I'm going to make use of our former radiology resident in the room. Adam, what is your kind of quick read of that CT?
Yeah, can you do it one more time?
Yeah.
There's a small pleural effusion. There's consolidated opacity, atelectasis in the left lung base, and the right lung base. I'd have to look at it more, but like it's always tough doing consolidation versus atelectasis onto the liver, which is fatty infiltration. Just
Great. So Adam correctly points out that there is consolidation in really the entire right lower lobe, and then some in the left lower lobe as well, whether it's atelectasis or consolidation. The liver is enlarged. And the other thing I think that was prominent is that, right, the lung that's in his chest looks a lot like the liver that's in his abdomen. The liver is darker, but the same consistency, the same blood flow. So they also call hepatization of the lung based on the CT, which should be a buzzword for something. So While you are in the room working him up, repeat troponin comes back at 25, and he has this EKG, which the nurse asks you, says, hey, it looks like he has some SP elevation. So, Julia,
Yep.
what is your, like, quick, I'm standing in the room and something needs to happen right here?
So I mean, SP elevation is definitely in 1 to 3, ABS, maybe ABR, to V2 through V6. I mean, I guess my concern would be acute myocardial infarction versus a pericarditis picture, just based on knowing that he has a huge infection in his lung, but definitely would be calling the cath lab.
Perfect. You can call the cath lab. Cath lab agrees, and they take him for a cath. He has mild CAD without a critical lesion, but he has severe LV dysfunction. So, additional labs return on this gentleman as well. His micro, his blood cultures are negative. His HIV is negative. His Legionella urine antigen is negative. His strep pneumo urine antigen is positive. And his respiratory culture has moderate strep pneumo. So at this point, you know he's got a strep pneumonia, possible LV dysfunction, or definitely has LV dysfunction, possible heart involvement, and he's got leukopenia. Is there any syndrome you guys are familiar with that ties all of that together? It's okay if you're not, that's also the purpose of this conference.
Can you repeat it one more time?
Yeah.
So he has alcohol use disorder, he is leukopenic, he has a pneumococcal infection, and he's sick. Yeah, so this man has a syndrome called alcoholic leukopenic pneumococcal sepsis, or ALT. What on earth is ALT? So, from 1985, these two guys described alcoholism, leukopenia, and pneumococcal sepsis in a group of people at Grady in Atlanta, and then the Emory VA as well. And essentially what they looked at was about 95 patients who came in with pneumococcal bacteremia. And of those patients, quite a few of them died. But there was a higher mortality in people who were ETOH users. And when they compared the mortality of people who had pneumococcal bacteremia, who were alcohol users and who were not alcohol users, they found that there was about a 30% mortality versus about a 60 to 80% mortality. So alcohol appeared to affect your risk for severe pneumococcal disease. It made you more sick, it made you leukopenic, and it tended to happen in a younger patient cohort. So from that, this is one of the lines from their study, that leukopenia was associated with a high mortality in our series, and there was this striking association of chronic alcoholism, ARDS, and leukopenia in patients with pneumococcal bacteremia. And so they actually named this syndrome ALPS, or alcoholic leukopenic pneumococcal sepsis. And this is something that you actually will not see infrequently at Denver Health once you recognize what's going on. So, about 10 years later, some of you guys might know one of the names on the byline here, but Mark Moss and people at that point, Denver General, University of Colorado, when we were back on 9th Avenue or near the old VA. The old VA did a retrospective look for about 5 years, looking at whether alcohol use increased your risk of ARDS, something that we all know now. And what they found was that yes, alcohol use did increase your risk of ARDS. And does anyone want to take a guess at how much it increased the risk? 20%. Got 20%. Anyone else? Price is Right style? Right, so Dante's pretty much right. So it's 50%, 52% versus 20%. And so if you were an alcohol user, you had a 52% risk of dying from ARDS, or developing ARDS, versus 20% if you were a non-alcohol user. And then if you were septic as well, that risk actually went up. So it was about 65% versus like 30%. And so sort of re-identifying that alcohol use is a modifiable risk factor for severe pneumococcal infection. So this is one of those things that whether you're an inpatient doctor or an outpatient doctor, you can always work on someone's alcohol use disorder. And so preventing that, giving them their Pneumovax and their Prevnar is highly relevant if someone will end up becoming critically ill. Okay, so his hospital course. So final diagnosis here, he had septic shock due to outs from a strep pneumo, community-acquired pneumonia. His notable events, he required high-dose vasopressors for an extended period of time. He ultimately developed dry gangrene of all of his extremities. He had a necrotizing pneumonia with a lung abscess. And then his family actually was able to come from Mexico. He was undocumented. And when they were all at the room, they transitioned him to hospice. So this patient, unfortunately, ultimately passed away. So when you guys look back, so same disease process, both of these people had strep pneumo, one was an alcohol user, one was not. The person with alcohol use disorder got significantly more ill, even though they had a chest x-ray, which initially looked relatively the same. All right. We got one more case to go. This old white guy here in the middle. Does anyone know who this white man is? Any guesses as to who this white man is?
Probably a neurologist. William Osler.
Nice.
Wait, really?
Yeah. So rule of thumb.
The father of medicine.
Rule of thumb, whenever you're guessing an old white person in a medicine conference with a mustache, if you guess like Osler, Halstead, or one of the Hopkins 4, you're probably not wrong. Okay. So our last case, this man's coming in with shortness of breath. He's a 59-year-old man with a history of psychosis, hypertension, spinal stenosis, with a 3-day history of shortness of breath, which he described as someone is choking me. So he's acutely ill, unable to provide further history, like our last gentleman. So he, again, has psychosis, hypertension, and spinal stenosis. No surgical history. He's a non-alcohol user, never has drank. He's a significant smoker, smokes a pack per day. Never used drugs. And we're going to get the same workup. So he's afebrile. He is remarkably hypotensive in the ER. He's tachy to 115. He's breathing 35 times per minute, and he's statting 88% on 5 meters. Does anyone in the room, recognizing a theme, want to take a guess what happens before this man gets to the NICU? He is sedated in the ED for increased work and breathing. So on exam, he is acute distress. He's ill of hearing. He has dry mucous membrane. He has tenderness of his right lateral chest wall and rails throughout his right lung field. He's tachycardic and has delayed cap refill. His labs, white count of 18.9, a BMP with a low bicarb, elevated creatinine, lactate 10, procal 12, and his ABG is also really not great. All right, so what's our one-liner for this guy? I guess next question, what do you guys think is going on with this man? Perfect. So septic shock from a pulmonary source. Probably some strep pneumonia. Great. So there's your problem recognition. There's a running theme for this conference. All right. So we get the first chest X-ray in the ER. So this chest X-ray is actually a bit more subtle. But we'll say, Anita, give us your read of this chest X-ray.
So it looks like he has some like infiltrate in the right lower, like lung field. Yeah. But other than that, it looks overall pretty normal. So.
Okay. And if you were going to call, what lobe is that?
Your right lower, because you can still see the heart border. So it's not the middle lobe. Yeah, the right lower.
Oh, yes, that's the right lower lobe, which Anita correctly called based on the fact that we can see the right middle lobe with the right heart border showing us the right middle lobe is probably spared. So he gets fluid resuscitated in the ER. His next X-ray after intubation shows this. So for this one, we'll say, Jacob, give us your read of this new one.
Sure, yeah. So, looks like you still have this worsening of this right lower lobe. The middle lobe still looks relatively preserved. It looks pretty fluffy. So I assume like an alveolar process as well. And maybe looks like a developing pleural effusion too. He's kind of lost that costophrenic angle as well.
So 4 hours later, Jacob says that this right lower lobe lesion has fluffed out or gotten worse, and right, he did a nice job, so we've completely lost that right hemidiaphragm. And so we still have preserved right heart border, so we can say this is pretty confidently a right lower lobe lesion, and then he's concerned about there being a pleural effusion there because he can't see any part of that costophrenic angle. And then I agree, like there's probably a little bit of fluffiness up here as well. And then I'll clear this out here. What other support devices, just so we're getting everything on here? This man has 2 support devices in place. What are they?
He has a central.
Perfect. So he's got a central line, he's got an ET tube. Great. So a worsening right lower lobe pneumonia, similar to every other case we've talked about today. Here is his CT, which was obtained after that chest X-ray. All right, I'll run through that one more time. At this point, there's probably a little bit of pattern recognition going on with what I'm doing here. But how about Dante? What's your take on the CT?
Yeah, it's a peak gas consolidation and like the right lower lobe. It kind of looks like that, like you were saying earlier, like that hepatization of the lung.
Great. Perfect. So this man has a dense right lower lobe pneumonia. Adam, anything else you could add to that?
Can you go a little further down?
Yeah.
And that right there. Is that I wonder about half that right there. Where is that pocket of air?
Yeah. Perfect. So Adam's concerned about an abscess with instant consolidation. All right. Before I show you guys the micro, does anyone want to take a wild guess what this man's micro is?
Strep pneumo.
All right. HIV is negative. His Legionella is negative. His strep pneumo urine antigen is negative. So a shocker, the urine antigen is negative. His respiratory culture is positive. So what do you guys make? What do you guys make of having a positive respiratory culture but a negative urine antigen? How many of you guys seen this problem?
Probably haven't seen it that often, but if you're isolating it out of a culture, I would trust the culture more than I would their urine antigen. I would treat them based on their culture data.
Awesome. So Meryl brings up a really good comment in the chat that the urine antigen is actually not as sensitive as we think it is.
Go, Meryl.
Yeah, Meryl's killing it. So right on, in rounds and awards and stuff, we always talk about with the medical students how the Legionella urine antigen is only the first serotype. Like we're all going to be reciting that when we're in nursing homes when we're older. But the thing we don't ever really talk about is that the strep pneumo urine antigen is also not perfect. And so the strep pneumo urine antigen, right, if it's in your urine, it had to have gotten to the urine somehow, right? We're not inoculating our urinary tracts with strep pneumo. And so it gets to the urinary tracts via the blood. And so the strep pneumo urine antigen is actually most effective in people that are bacteremic. And so if you're bacteremic or transiently bacteremic, your strep pneumo urine antigen will be more effective. What do you guys think the sensitivity for the strep pneumo urine antigen is if you're not bacteremic?
50%.
Like it's got 50? 20.
Oh my God, terribly low.
We're all tracking. So it's not that bad. So it's 70%. And so if you're not bacteremic, the sensitivity of the strep pneumo urine antigen is 70%, which is still not great. Which is why we always try to give respiratory cultures at the same time, even though the respiratory cultures are often not the most helpful thing in the world. If you are bacteremic, this sensitivity increases to about 85%. So a pretty significant change. So just because your person has a negative strep pneumo urine antigen doesn't necessarily mean you should stop the ceftriaxone day 1. Please continue to treat them for CAP appropriately. Okay. So this man has a strep pneumo right lower lobe pneumonia. And so the reason I showed Osler on that first page is Osler stole a line from a much, much older English guy and described pneumococcus as captain of the men of death, which is like the most dramatic way to describe an infection I've ever heard in my life, but I think it's great. And so this man is attempting to be carried off by the men of death and remains extremely hypotensive. So for our Mickey residents right now, you guys probably dealt with this quite a bit, people who are trying to die in front of you. So what is our algorithm for improving this man's blood pressure?
For levo, usually first line.
Cool, so we're going to start him on levo. Great.
Yeah, assuming he's in food,
Yes, we'll say he's already got his 30 cc's per kilogram. So we start him on levo. What dose of levo do you guys want to start him at?
0.05. Just start on a hefty dose.
All right, perfect. So 0.05 is the low dose, so you can start him at anything higher than that, but 0.05 is like our starting dose of levo. We'll say that after you start him on levo, he remains persistently hypotensive with a MAP that's less than 65. What do we do next? Vaso, perfect. And what do you guys want to do with this vaso dosing?
Set at 0.04.
Oh, so we set it at 0.04, we set it and forget it, right? We don't titrate vaso. Does anyone know why we don't titrate vaso?
We talked a little bit this morning about there's a study that showed that if you add this at 0.04 when you have levo at a reasonably low dose, they had better outcomes than if you were to increase, right? Is that what we?
I missed that.
Something to that degree.
Yeah.
The VAST, thank you. Yes, it was a Canadian study.
Was I part of
That
this
showed,
one?
oh, maybe you weren't.
Okay.
Yeah, so Dante is correctly describing the VAST study. So what the VAST study looked at back in the mid-2000s was whether adding vasopressin to norepinephrine or just increasing the norepinephrine dose changed mortality in people with septic shock or all comers with shock. And what they found was there was no change in mortality, but with vasopressin, you could give a lower dose of norepinephrine. And there was a trend towards improved mortality if people were getting vaso when the norepinephrine dose was about 0.15. So if you were on low-dose norepinephrine early in the course of your septic shock, there was a trend towards improved mortality when you added vasopressin. And so what this looks like from a resident perspective is, right, if your person is crashing, your attending's not in the room, the fellow's not in the room, if you hit a dose of 0.015 to 0.02 of your levo, add vaso. Add vaso and get it started. You can always take vaso off, you can always titrate levo down, but that threshold of 0.15 to 0.2 should be when we start thinking about adding vaso. All right, so we've added levo, we've added vaso. This man is still incredibly sick. What do you guys want to do next? He's still hypotensive.
Stress dose steroids.
Perfect. Stress dose steroids. I like it. So kind of a trick question. The answer right there was not another pressor. And again, what dose do you guys want to give him?
I give her 50 Q6.
Or 100 Q8.
Or 100 Q8.
Dante's got that third week of NICU reciting the hydrocort dose. Perfect. So you give him the hydrocort 50 Q6 hours. There's been a ton of literature about this, a bunch of really great named trials, but essentially what this does is it decreases your ICU length of stay, and it decreases sort of ventilator days, and it decreases vasopressor requirements. There is probably no effect on mortality. Some say it's shown improvement in mortality, others have shown no benefit, but we can reasonably infer that all of these things are beneficial for patients.
Do you use like fludrocortisone?
Yeah, great question. So Evan brings up whether you use fludrocortisone. So a few of the studies looked at fludrocortisone in addition to hydrocortisone. Interestingly enough, those were the studies that showed mortality benefit. As a practice point, we don't do fludrocortisone here, and I've never ordered it in residency, but the studies that have shown mortality benefit have shown it. Hydrocortisone by itself has mineralocorticoid effects, and so you are getting some of that benefit, whereas dexamethasone does not, which is why it's a little bit more neutral. Okay, he's still hypotensive after the stress dose steroids. You got one more thing to add. Epi or what else?
Okay.
So epi or phenyl, and at this point, dosing your T's and P's, find the nearest God that you like to pray to, and you start titrating. Perfect. But I would encourage you guys, if you're seeing a patient who's acutely hypotensive, there is no harm in starting these medicines early. Your fellow and your attending can always help you titrate them down or off, but at least having a nurse go grab them because there is a little bit of a delay is incredibly helpful. you guys correctly started this man on all of these medicines, and you diagnosed him with vasopressor refractory septic shock due to strep pneumo community-acquired pneumonia. So you called him vasopressor refractory because you required at least 2 pressors to maintain a blood pressure of a MAP of greater than 65. So notable then for this gentleman, he was rapidly titrated to 3 vasopressors, norepinephrine, vasopressin, and phenylephrine, within about an hour of being in the Denver Health NICU. He received stress dose steroids, like Anita said. His hemodynamics got better after 24 hours. He self-extubated on day 3 because he was ready to go. He was discharged home on day 7. So, what are some learning points from these 3 cases today? So I think one of the things I wanted you guys to take away from this was that strep pneumo, we see it a ton, but it causes a really, really wide spectrum of clinical illness, from empyemas to ALPS to just your run-of-the-mill horrible septic shock, and just general floor emissions for pneumonia. We talked about the MIST-2 trial, so giving people TPA and DNA because they've got an empyema to help break up the loculations and improve drainage. We talked about the limitations of the strep pneumo urine antigen. It's not the most sensitive test in the world for patients on bacteremic. And then we talked about how alcohol use disorder is a modifiable risk factor for strep pneumo infection, and so in the clinic we should always be talking to people about how we can decrease the amount they're drinking. We should give them Pneumovax if they're alcohol users or Prevnar. And then we talked about alcoholic leukopenic pneumococcal sepsis, one of my favorite diagnoses. And I guarantee you, one person in this room will diagnose this year. It's a fantastic illness to diagnose, but it has an absolutely horrible mortality associated with it. All right, what questions do you guys have? Perfect. Any questions from the chat? Thank you guys for